I'm happy to start our 2021 interviews in our program of interviews with the experts. This time, I'm happy to introduce to you Dr. Adam Braimowet. Adam got started very early on in cognitive behavioral therapy, specifically insomnia, or as we will call it CBTI, as we continue our conversation. He started at the time of his doctoral degree here at the University of North Texas, where he got his doctoral degree in clinical health psychology and behavioral medicine. He followed up with an internship at the University of Florida Health Science Center and got board certified in behavioral sleep medicine, did an advanced fellowship in mental illness research and treatment at the VA Pittsburgh Healthcare, where he has remained now for a number of years, becoming the associate director of the program as it relates to the advanced fellowship program. So Adam, I welcome you. I thank you for sharing your thoughts about this. There's nothing more relevant perhaps in sleep, given the year that we have gone through 2020 into March of 2021. We started a year ago thinking, well, this might be serious, and indeed it was serious, affected us all, affected everyone's sleep, and we will be interested to hear your comments about the topic. In terms of cognitive behavioral therapy of insomnia, I would start out by asking you, what's the latest on the traditional protocol that has been had been introduced many years ago, many variations of that, but I would like to start by you kind of reflecting on what are your thoughts about the traditional protocol as it relates to CBTI, the combination of both behavioral and cognitive interventions that are foreseen in the protocol, the length of the protocol, the number of sessions, the intervals of the sessions. Just a brief update on your thoughts on the traditional CBTI protocol.
Yeah, absolutely. I think that kind of standard CBTI, as many of us know it, so having the main components of stimulus control, sleep restriction, cognitive therapy, relaxation, and aspects of sleep hygiene, and of course, psychoeducation. In a kind of, I think most protocols in a general 6 sessions is still has the strongest evidence base. And, going back to early, almost 20 years ago with NIH and then various other organizations looking at the evidence, and more recently, the American College of Physicians, the VA DoD guidelines, and just a few weeks ago, the American Academy of Sleep Medicine kind of, again, giving that support that CBTI is the first line intervention. There are certainly adaptations. There are briefer protocols. This is something that my research involves. So one version of the brief behavioral treatment for insomnia is a 4-session protocol, and the sessions tend to be shorter in duration as opposed to a 45-minute or 50-minute therapeutic hour. Sessions might be closer to 30 minutes or less. So that research is newer. So I just don't think there's enough to perhaps bring it at the same level, certainly the same level of evidence as what we consider traditional CBTI. But I think when you look at CBTI in practice versus CBTI in research protocols, there are certainly differences. And, in just talking with colleagues and looking at what's done in real world clinics is, I think CBTI can sometimes often look more like some of these adaptations. You are adapting treatment to the individual treatment responses of the patient. And if that's occurring in 3, 4, 5 sessions, no, you certainly don't always need to have 6, 7, 8 sessions of treatment if it's not necessary. I think you also will start to see variations in how treatment is delivered in terms of the overall duration. So you might traditionally think of CBTI, it's weekly sessions, but perhaps you're doing some weekly sessions in the early part of treatment and lengthening sessions further out, maybe treating them more as booster sessions. So I think there's a lot of variability, especially when we think of how CBTI is delivered in the real world versus the research protocols. But for the most part, and when we look at just the evidence, which are typically based on these randomized clinical trials, is I think more often than not, CBTI 6 weekly sessions still has the strongest evidence base.
And the same kind of, well, not the same, but on the brief behavioral treatment for insomnia that you mentioned, over what period of time are you structuring that? And I know that you have been interested in testing the non-inferiority kind of comparison with the traditional CBTI. I don't assume that there's anything new, but if you have something new on that, any updates, we would be interested. But what's your impression? I think you make an important point that sometimes it's lost. We are reading a lot of good research protocols on CBTI and variations of CBTI, but in the real world, things are different, and we will touch on that in a second. But in terms of the BBTI, the brief behavioral treatment, over what period of time do you deliver it, and what are your impressions at this point?
Mm-hmm. So I think the starting point is typically weekly sessions. And so for BBTI, it might be 4 weekly sessions, again, closer to those 30-minute sessions. And the research I've done, while I'm more interested in kind of the pragmatic approach, what's happening in real world clinics, but recent research I've done that did a head-to-head comparison of BBTI versus CBTI, and the goal was to do it in weekly sessions and try not to take more than every other week. And what we found is that there were no significant differences between the groups, that the 4-session BBTI versus the 5 or 6 session CBTI, that both resulted in significant reduction of insomnia symptoms and improvement in overall sleep quality. And while the goal was to see is BBTI non-inferior, we weren't able to establish that, I think just from our a priori methodology and the approach we took is the sample would have needed to be much larger to truly establish that. But I think at least, in kind of my interpretation of the results and kind of using that for additional research that I've received funding for, is that BBTI certainly is an effective treatment, that it involves this reduction, and in a similar time frame as CBTI, if not a shorter time frame.
And how, coming back to CBT, and perhaps to any modifications you do on the BBTI, how should, in your experience, the treatment be modified, or what considerations should be made with the very important psychiatric comorbidities that insomnia has? And that's a topic that is not consistently discussed, but it's very important. So it would be relevant to hear your comments about.
Yeah, and this is something we try to account for in the study, and to see, because I think in CBTI over the past several decades has been shown to be effective kind of across the board in different subpopulations, whether it's psychiatric comorbidity, depression, anxiety, PTSD, I think even substance use, or medical comorbidities like chronic pain, or arthritis, TBI, that it still can be an effective treatment. Focusing on psychiatric comorbidities is, I think, when the adaptations can become more critical, and certainly can pay more attention, and you may need to potentially integrate other aspects of treatment even outside of insomnia to get the best effect. And one thing to I think consider is for these individuals with comorbid psychiatric disorders is what is the priority of treatment. If you have someone coming in who is really treatment naive for any issues, I think it is important to determine, is it the depression that should be focused on? Is it the insomnia? And sometimes the patient doesn't always know, and sometimes it's a chicken or the egg, and you could start either way and still have good outcomes. Insomnia actually, I think, is advantageous because sometimes it can be seen as almost this safer treatment. Even though insomnia is considered a psychiatric disorder, it is often more medicalized. So there's often less stigma surrounding it. So for a patient who maybe has never engaged in psychotherapy, working on sleep might be more approachable and almost a gateway into kind of broader treatment. So I think you also need to consider with psychiatric comorbidity, what is kind of what's the level of severity, certainly. I think PTSD, in which insomnia is very highly comorbid, is if this is an individual who is maybe not even leaving the house very often, still has a lot, maybe, having flashbacks, having significant nightmares, that might not be someone who is ready to engage in insomnia work. On the flip side, there's actually really exciting research about specifically PTSD and insomnia and the order and the combination of treatment. And there's some good evidence showing that starting with insomnia might be more advantageous, that even if all these other significant PTSD symptoms are prevalent, that by focusing on the sleep, it can kind of get that patient, again, maybe more prepared to manage the really challenging aspects of dealing with trauma. Even I think on a neurobiological level, is that if sleep is improved, perhaps the brain can process the trauma more effectively. So I think it's all very new research. We're learning a lot. So those are some aspects of managing comorbidities with sleep.
And so relevant to that is the challenge of dropouts. What is the rate or the range of rates that you see, and is there any data or any expertise you have developed over the years as to rescue interventions, if you will, to address the challenge of dropouts?
I think dropout in psychotherapy in general is always an issue, and is always something clinical psychologists and other mental health providers are trying to, enhance that engagement of care. Because, if there isn't that engagement, if you're dropping out midway through treatment, is there enough benefit happening? And it could have long-term effects, or someone might say, well, I tried psychotherapy. It didn't work, for a variety of reasons. And it's not always what's happening within therapy. A lot of times it's what's happening outside of therapy, what's happening in their life. And this is something, again, in general, I think before treatment even starts, you kind of have to make sure, are you ready to engage? Are you ready to put the work in? Because therapy is work, especially insomnia, which involves a lot of behavior change. We know behavior change is hard, whether it's weight loss or exercise or diet.
So you mentioned this issue, the patient needs to be ready for it, which obviously it's important even in sleep apnea. If the patient is not ready to acknowledge that they have a problem, they will never make the behavioral commitment to use a device. So I think that's a very important point. But beyond that, is there any particular profile of patients that are likely to have higher dropout rates?
That's a good question. I don't think there's a definitive answer yet. This is some work I'm doing with large data sets in the VA. Is that, can we identify aspects of an individual from the medical record, so demographics, other healthcare issues that might help predict engagement in care. But I think it's looking, again, kind of going back to what we talked about previously, is that what is the what other disorders are they dealing with and how are they managing those? So you might say if an individual perhaps isn't having good management of hypertension or diabetes, then would that be potentially predictive of engaging in psychotherapy? Again, you look at severity of comorbidities, and that if those are not well managed, engaging in a behaviorally focused treatment could put them at risk. But you do see data that even with higher levels of severity, whether it's insomnia or other comorbidities, that if they do engage in care, they often have good outcomes, that they're able to reduce that. So, that's not an answer you're looking for, I suppose.
No, that's
but I think
perfectly
this
okay.
is the data we're learning from, and you might need really large data sets to really be able to identify these factors related to patients or build these phenotypes. Where genetics data is getting better and better, perhaps we'll start to identify specific genes that are even related to, obviously related to sleep, but maybe even related to other aspects of engaging in therapy. I think that's well in the future, but looking at an individual's internal motivation, there are some ways we can measure that, but I think preparing them early in the process, maybe even starting from the physician who initially diagnoses, if this is in the primary care setting or even in psychiatry, and then before they even get to the psychologist, making sure they have a good understanding of what's involved in therapy. And some of the work that we did together in your clinic in Dallas, and kind of learning about when do patients drop out. So if a patient drops out, when does it typically happen? And it's often early in treatment. And with sleep, that's kind of the hardest part when we make those changes of where we might be drastically changing their sleep behaviors, going from spending 8-9 hours in bed and saying, you now only get 6 hours in bed. You have to be up much later. You have to be awake much earlier. And again, that's hard. That's a kind of a shock to the system. So that's when we do see patients dropping out of treatment, is early on, kind of when we're telling them this is what's going to happen, or when we actually start implementing that and modifying those behaviors.
So on the flip side, on the positive side, there have been over the years a number of studies on the effectiveness of CBTI. And now that the field has come of age, what's your impression of effectiveness, not 1 year out, but perhaps several years out? What percent of these patients, for example, benefit from what you call the booster sessions? Is there any data on that, perhaps?
There's limited data. There was a recent paper that I think found that anywhere from a year to 4 years, maybe even 10 years, again, likely smaller sample sizes, but show that I think of those patients who are completing treatment and responding to treatment have long-term gains. And I think that's really based on the foundation of CBTI, which is we're teaching skills. We're hopefully when somebody leaves treatment, is they're prepared to deal with the insomnia that's going to come back in an acute form, almost guaranteed. I mean, that's the way insomnia works. There are stressors that happen, it disrupts sleep. So hopefully, whether through just that initial course of treatment, or perhaps if you engage them in booster sessions 1, 3, 6 months out, maybe that could be interesting research, is a course of treatment and everybody gets at least a booster at 1 year. How does that enhance their treatment outcomes? But I think most patients who can engage in treatment, see that initial response, will see those gains years in the future, I think, unless there are maybe other significant setbacks. And you can certainly develop chronic insomnia again, and hopefully they can remember those skills or re-engage in care, and perhaps it's a quicker course of treatment, is that it's just remembering what to do, having a little bit of help from the clinician to put those skills in place again.
So an impossible question from a methodological perspective, but one that I would be interested to hear your thoughts. So what are the most enduring benefits from therapy? In a way, you get at it potentially long-term with the BBTI, but what's more critical? And I don't assume there's a 100% answer to it, but I just want to kind of hear your thoughts about it. Behavioral intervention versus cognitive reframing. What, not in the short run, because it's whatever works is welcome, but if you look at long term, what is more important in terms of long-term outcome from your experience? I don't assume there's any consistent data on that.
There's not consistent data. And so I'll come back to what I think might be the only study or the one that comes to mind. In my opinion, it is the behavior change. I think that really is the foundation of changing your sleep behaviors. Is that if you don't have the stimulus control, which is kind of having more control over your sleep environment, removing the non-sleep activities from the bed, and having that structure, so sleep restriction or time in bed training, if that structure and paying attention to those behaviors aren't there, I think it's much more challenging to have long-lasting benefit. Now, this is where some individual difference come into play, is that when you have very, maybe a very anxious patient, someone with more cognitive arousal, is where the cognitive therapy techniques can be very beneficial. And again, the one study that comes to mind is Allison Harvey did a sort of dismantling study looking at cognitive therapy alone, behavioral therapy alone, and full CBTI. And all treatments were effective. There were some slight differences at different time points, but the cognitive therapy alone was still effective, but I hope I'm remembering this correctly, I think the behavioral therapy and the full package long-term were slightly better. But I think for most patients, that if you don't have the behavioral change, the behavioral components, then the improvements will be perhaps less, and I think the long-term gains may not be there.
So kind of bringing the discussion to date, we have gone through 12 months that has shaken our routines, our sleep behaviors, our work behaviors. So there could not have been a better time to have digital platforms, telemedicine, and obviously there has been a push for digital platforms for CBTI that are commercially available. So in the context of COVID-19, Adam, how have you adjusted your treatment protocols and how have they performed?
So for the past year, I've been conducting all virtual care. So either video or phone, and that may just depend on the patient's kind of what technology resources they have available to them or their preference of interacting. For the most part, virtual care has been successful, I think. And even before COVID, there's some good data that virtual care, kind of focusing on veterans or individuals who live more in rural communities, live far away from medical centers where the care might be available, found that virtual care is effective. So I think it comes down to individual differences. We can say, how is this treatment performed? I think for most of my patients, it's been fairly similar, especially if it's by video and if they utilize kind of different resources that allow for the sharing of documents and outcome measures. That's a big part of CBTI is we still use kind of paper pencil type measures to track whether it's a sleep diary or the insomnia severity index. So those are all key aspects of treatment. And if we can share those documents, it really enables treatment. When that isn't as readily available, something like the sleep diary, if I have to mail it to a patient, they're reading it over the phone, it can be done, but I think that can add more challenges to treatment. So I think for those patients, those might be the patients who I would prefer to have come into the office, but the risk benefit may not be there of seeing them in person. So, again, I think a lot of patients do well with virtual care and may even prefer it, and it may be here to stay. but I think there are always going to be those patients who working in person, that's going to be most beneficial for them.
So coming to an end of such an enjoyable conversation, what is your vision of CBTI behavioral therapy 5 years from now? What's the crystal ball on your side? And as you prepare and kind of strategize your research, where are things going to be?
Mm-hmm. You know, I think with what we've been able to accomplish with virtual care, like I said, I think it may be here to stay. And I think we'll see both more research and just clinical practices integrating virtual care and to meet the needs of our patients. And that's a big part of having effective treatment. I think you alluded to the digital platforms that are more self-management. There's good research that works. And I think it's identifying which patients that's going to work for the best. You know, giving everybody a digital platform as the first line of treatment, I don't think it's appropriate. I don't think the research supports that either.
What is your concern with that? Because of course, there you get into the commercial aspects of this, and it's an important kind of discussion to have from the clinical, the research perspective.
I think it's looking at the full picture. There's good evidence that it's effective, but who are the individuals that are participating in that research? Perhaps they're more motivated to use technology. So I think you need to pay close attention to what are the patient's priorities of treatment. Is maybe I've had patients say, sure, I could use the digital intervention, but I know if I don't have a provider to kind of be there to support me, I'm not going to engage in care. So I think that's why we still need this spectrum of care, and whether it's, you think of it from a stepped care perspective or more of a precision medicine approach, is we need to be better at matching patients to the care that's going to work best for them. And sometimes it is a trial and error process. Is we start them on a digital intervention that's very self-managed, or there's workbooks also if the technology isn't what they want to use. But again, we can start with self-management and kind of go up the ladder. You know, for my own research, I'm very interested in accessing care, especially like in the primary care setting, where I think insomnia still lives for a good portion of patients. You know, they're telling their PCPs they have insomnia, and are they getting a medication, or are they going to get access to treatment? That access to behavioral treatment isn't always there. So my research is more focused on how can we train mental health providers who work in primary care settings to deliver BBTI for the patient who is maybe more mild to moderate, may not have too many complex comorbidities, and who maybe doesn't want to have to go to a specialty mental health clinic for insomnia. You know, can a good chunk of insomnia be treated with evidence-based behavioral therapy in the primary care setting? So I'm working on both training providers, but also from an implementation perspective of what are the strategies that need to be in place so that this is sustainable. When you do research, you have funding, you can often make it work. But when that funding is taken away, how can we have sustainable delivery of care in these different settings? You know, if you have a psychologist trained in CBTI and behavioral sleep medicine, you know, and we have a private practice or a clinic, we can get referrals, but that's a very small portion. So I think if we can, whether it's primary care or other clinics that see patients with a lot of insomnia, if we can start to implement the delivery of care in those settings, you know, when the infrastructure is in place to support it, I think that will really provide a lot better care at the kind of a population health level for individuals with insomnia.
Are there any other additional behavioral interventions on the horizon that you think might evolve to a level of evidence-based data that will make them viable?
I think so. You know, certainly there's the different adaptations or iterations of CBTI, whether it's BBTI or there's some brief cognitive treatments, again, more focused on primary care. There is another treatment that's, again, it's newer. It's called Transdiagnostic Intervention for Sleep and Circadian Rhythm Disorders. And it starts to more formally integrate aspects of the impact of your circadian rhythm, as well as with CBTI, as well as things like motivational interviewing and other kind of well-supported therapeutic techniques to enhance engagement. It's adaptable for issues like comorbid sleep apnea. So if you need to help a patient with adherence to wearing their PAP, that's more easily integrated into this treatment. And so I think, and I hope we'll see more support for this treatment and more implementation broadly, because I think there's promise. So it's CBTI plus.
Excellent. Adam, so good to catch up with you and to hear about all the interesting things that you are doing, and good luck on the future endeavors.
Well, thank you very much. It was a pleasure talking with you and great to see you again.